Good evening and welcome to Doctors on Call. I'm Dr. Peter Nalin, Professor and Head of the Department of Family Medicine and Biobehavioral Health and Associate Dean for Rural Medicine at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on eye problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Charlie Ahrens, an ophthalmologist with St. Luke's Eye Care, Miller Creek Medical Clinic; Dr. Matthew Kosick, an ophthalmologist with Essentia Health; and Dr. Lisa Graham, an ophthalmologist with Ralph Eye Care Specialists in Hermantown. Our medical students answering the phones tonight are Barrett Bukowick from War Road, Minnesota, Kenny Knudsen of Cambridge, Minnesota, and Katie McLaughlin from Hibbing. And now on to tonight's program on eye problems. And we already have questions from our callers. Dr. Ahrens, what is the, Dr. Kosick, this one's for you. What is the difference between optometry and ophthalmology?
Well, that's an excellent question. There are two different professionals that care for the eye, and we work well together. The three of us on the panel tonight are ophthalmologists, and what that means is that we went to medical school and earned our medical degree in 4-year training after college, and then we went on to complete an internship usually in a hospital caring for all sorts of general medical issues. We then completed 3 years of residency in ophthalmology, and that's really the most important part. During those 3 years, we did hundreds of surgeries where we were observed by other ophthalmologists, and we learned right next to experienced doctors. Most ophthalmologists will do about 200 cataract surgeries under the supervision of someone else during this period. And then after that, there's an optional period where you could complete a fellowship training in a certain specialty like glaucoma, oculoplastics, pediatrics, retina, or cornea. And so that's the path of an ophthalmologist. An optometrist will complete college and go to optometry school for 4 years. They'll learn fitting glasses and contacts and also learn about eye disease. But they don't have that training of the ophthalmology residency, which is very important for doing any procedures and treatment of advanced disease on the eyes.
Thank you. Dr. Graham, what is the relationship between dry eyes and computer use?
A strong relationship. So dry eye is very common, especially in the winter in Minnesota. So I'd say a lot of folks suffer from dry eye symptoms with any visual tasks, reading, crocheting, watching TV, driving. You can have grittiness, burning, blurring of your vision, even watery eyes. And computers, we spend a lot of time on our devices, computers, laptops, phones, and they can definitely cause your eyes to be dry as well. You don't blink as often when you're looking at something. And so you're not coating your eyes with fresh tears as consistently and your eyes can dry out. So a lot of computer syndrome is really just dry eyes.
Thank you. Dr. Ahrens, what is the treatment for a cataract in childhood?
Cataracts in childhood is a pretty unique disease process. It's not the same as when we're older. If a pediatric patient develops cataract, it's usually within the first 1 or 2 years of life, and it can be significantly disabling for that child, especially long term, as far as developing amblyopia or lazy eye. And so we have to be pretty aggressive with cataracts in childhood. Usually those are performed by basically a pediatric subspecialist who really likes doing and is really good at doing cataract surgery. And so they do have a few of those subspecialists in the Minnesota area, but we also then have to watch long-term for things like glaucoma because there's such a high association with glaucoma and pediatric cataracts. So these are lifelong patients that we need to be aware of very early on and get them treatment very early on. And it's a lot different than the older patients who slowly develop cataracts over time because of how disabling the vision can be just having that cataract either when they're born or when they develop it really early on.
Dr. Kosick, what holds a lens implant in place?
That's a great question. The cataract, which is formed in the eye from cloudiness in your natural lens, so that natural lens is formed of cells that are clear when you're younger, that becomes a cataract and needs to be removed surgically. And so your question asker is asking about the plastic lens that we put in when we remove the cataract. And there's a fine layer of cells around the cataract that are held in place by wires called zonules. And it's especially important here in northern Minnesota because many of our patients are Northern European or Scandinavian and have a condition which gives them very weak zonules. So there's no need for glue. There's no need for stitches in the vast majority of cases because we're using the structures that are already in place in the eye to hold the lens in place.
Thank you. Dr. Graham, a caller wants to know, after experiencing iritis and uveitis 3 times in 3 years with testing not showing Graves' disease, why might this be occurring?
Wow, the differential diagnosis or the array of medical problems that can cause uveitis is huge. Graves' disease is actually not a common one. So if a patient has more than one episode of uveitis, or commonly called iritis as well, they should be tested for sort of a myriad of things. Blood tests, perhaps a chest x-ray, tuberculosis, like a skin test. It's a vast differential diagnosis. A lot of times, unfortunately, all those tests come back negative, and we just end up treating the recurrences of uveitis as they come up. But that patient should at least be tested for a cause.
Okay, thank you. Dr. Kosick, what would be a reason to operate on the muscles of the eye?
The muscles of the eye move the eye around, and so this often comes up in pediatrics because a child may have an eye that's turned in or turned out, and in order to change the positioning of the eye, you operate on the muscles by either tightening them or relaxing them. And these are the main reasons to operate there. In thyroid eye disease, for example, you may also have involvement of the eye muscles to relax them and align them.
Thank you. Dr. Ahrens, what causes intermittent double vision and what could be a treatment?
That's a complex question as well. Just like Dr. Graham was saying, there's a large spectrum of things that can cause double vision, particularly if it's intermittent. As a specialist, when we see these patients that walk in and the patient is having double vision, we generally will kind of start to try and break it down into, is it only in one eye? Is it in both eyes? Depending on if it's in one eye, generally we get to take a step back because there's only a couple of places that could be, either tear film, cornea, lens. There's not going to be a lot of other things that it can be. So it could be as simple as dry eye, which Dr. Graham had talked about earlier, particularly if it's intermittent in nature. We see that quite frequently, especially in the last couple of months because of all the long winter that we're having now. If it's in both eyes, we all generally have a little bit of a misalignment, like Dr. Kosick had mentioned, and our brains are able to fuse our two eyes together, but sometimes if we're getting really tired or anything like that, it'll start to break down a little bit and we can get double vision. We focus back in and get it back to single. As long as it's not problematic and not affecting our activities of daily living, most of the time we can just watch it. If it's problematic, affecting our daily living, or there's other neurologic signs or symptoms, those need to be worked up and you should be seeing an ophthalmologist like us to do that.
Thank you. Dr. Graham, what could be the association between hyperpigmentation and macular degeneration?
I'm not sure exactly what you mean by hyperpigmentation. Let's start with macular degeneration. Macular degeneration is a disease that is quite common. About 25% of the people as they age over the age of 50 or 60 develop some macular degeneration. Some of it is visually debilitating, And some people lead a very normal life. When we are looking for macular degeneration signs, we see sort of a hyperpigmentation of the retina that indicates scarring and progression towards vision loss. So,
thank you for that. We have a question on Fuchs dystrophy. What can be a cause or treatment?
Sure. So this is a condition, given that it's a dystrophy, it's genetic and inherited, although it is possible that one of your parents may not have known that they carried this condition, so you may be the first to know about it. And that, what it is it's a problem with the water pumps of the cornea. The cornea is the front windshield of the eye, and because the inside of the cornea is against water, what we call the aqueous humor, it has to pump that water back out so that it does not become swollen up. And in this dystrophy, those pumps fail to work. And that can be worsened by surgeries inside the eye because it puts stresses on those cells that pump the water out. The other thing that will cause this condition to worsen is just simply aging. We have thought in the past that using a saltwater drop called Muro can help to dry out the cornea and help these pumps along, but some more recent studies have said that it may not do very much, and I think many of our patients would agree that it often doesn't do much. So most of the patients are most symptomatic early in the morning because their eyelids have been closed and their corneas have not been able to dry out, and they have blurry vision that can clear up through the day. And if it's very bad, it may go on to require a cornea transplant.
Thank you. Dr. Ahrens, how do ophthalmic beta blockers help glaucoma?
So to not get too into the nitty-gritty of the biomechanics of all the drops, basically when we're talking about glaucoma, which is a specific damage to the optic nerve, there's a large variety of different risk factors that are associated with it. One of them, and the only modifiable risk factor, is the pressure inside the eye. And so that's how we treat it, is we lower the pressure. Any of these processes like beta blockers or the most common ones that we use would be like prostaglandin analogs. They're all geared towards either decreasing the amount of fluid that's pumped into the eye, like Dr. Kosick was saying, the aqueous humor, or increasing the outflow of the fluid when it drains, because it's constantly being recycled and put back into our circulatory system. So between the beta blockers, the latanoprost, and all of our different medicines that we're using, we're basically trying to turn down the faucet or turn up the drain to get things to drain out to lower the pressure inside the eye.
Dr. Graham, this question is, what are a few uses for a donated eye after death?
Donor eyes are very useful. One of the first organs ever transplanted was the cornea, the clear window in the front of the eye, and it can be damaged by an infection or trauma or Fuchs dystrophy. So corneal transplants, they're not common, but they happen fairly regularly, and they can restore sight to somebody who's blind in an eye. So that's a very critical use. Over the years, we've also used the tendons of the eye muscles. We've used the wall of the eye, the white of the eye, which is called the sclera. So various uses for those tissues. And then we're all familiar with using banked eyes that aren't suitable for other uses on patients for training. So we learn how to operate by starting with donated eyes. So they're critical.
Very important.
Yeah.
Dr. Kosick, what is the postoperative advice regarding mask wearing after eye surgery?
Sure, that's a very timely and interesting question. I think the most informative data on this subject came from the British Journal of Ophthalmology in the fall of last year. And in Japan, they did a review where they looked at 30,000 cataract surgeries, and half of them were completed before COVID, and half of the surgeries were completed after COVID. And what they found was the rate of infection in the eye was about 1 in 1,000, and this was before COVID. In the after COVID period, the rate of infection was 2 in 1,000. So a doubling of the infection rate. And what's more interesting is that of the strains of the bacteria that they were able to culture, the increased cases were accounted for by Streptococcus bacteria, which is found in your mouth. And so this is not a bacteria we typically find in the eyes. And so this study would suggest that because of the masking in patients who have recently had eye surgery, they may be exposed to bacteria from their mouth, and it could get into the eyes. It's worth talking with your doctor about the risks and benefits of wearing a mask, especially when you've had a recent surgery and your eye still has a wound that has yet to heal.
Thank you. Dr. Ahrens, are there any exercises that can be done to promote eye health as we age?
Eye exercises is kind of an interesting question sometimes because it gets tossed around as far as like there's programs called vision therapy and things like that, which can sometimes be beneficial in their own way. The only eye exercises that we really see that we have evidence, peer-reviewed evidence-based medicine that really works is in an entity called accommodative insufficiency. And what that is where when we look up close, we do a couple of things, our natural reflexes. We turn our eyes in to see things, we accommodate or kind of crank in power to see up close, and our pupils constrict. And so that turning in, as we age particularly, can sometimes slow down and we can get double vision when we're reading. We see it more commonly in patients with, say, like Parkinson's and things like that. So there are pencil push-up exercises and things like that where we slowly will bring, the tip of a pencil or the tip of a finger in slowly while we're trying to pull our eyes in. That can help. It's kind of a rigorous thing to do and gets kind of annoying doing it, but that has shown benefit to be beneficial.
Thank you. Dr. Graham, this caller wants to know about vein occlusion. What causes impending vein occlusion of the eye?
Well, folks who have vein occlusions tend to have significant cardiovascular risk factors like diabetes, high blood pressure, high cholesterol. Sometimes they've had previous strokes. The changes in the arteries tend to compress the veins, the adjacent veins, which causes turbulent blood flow within the veins and then a clot and blocks the venous drainage from the eye. When blood backs up in the eye, it can do a lot of damage. Depending on how extensive the vein occlusion is, it can actually cause blindness and just a series of compounding problems going forward. A small vein occlusion might go unnoticed by a patient and could heal just fine.
Very good. Thank you. Dr. Kosick, a caller asks about a type of Mayo Clinic custom cataract lenses requiring no glasses afterward. Is that familiar?
Sure, yep. There are lenses which we put in the eye following cataract surgery that are covered as part of the cataract surgery. And these offer some of the crispest, best quality vision you can have. They're very simple lenses, and they only focus light from one distance. But there are lenses available, which are referred to as premium intraocular lenses, that can focus light in different ways. These are available to anyone across the country, including patients here in Duluth. It's not particular to the Mayo Clinic. There's a couple reasons why patients might want these lenses. The first is if they have astigmatism, which is an irregular shape to their cornea, the lenses to correct that will not fix the cornea, but they can cancel it out in the same way that your glasses might cancel out the astigmatism. Those are called toric lenses. Then there are lenses that are becoming more popular, which can focus multiple distances at once, near, far, and intermediate. These lenses are great for patients who want to be independent of glasses, but we do know that they have slight decreases in contrast sensitivity and more glare because the lens itself is more complicated. So there are certain patients that may not be good candidates to have those lenses put in, and additionally, they cost more.
Thank you. Dr. Ahrens, a caller anticipates cataract surgery on Monday. Do they anticipate being put to sleep for the operation?
it's not me, so I know, because I don't operate on Monday, so and it's none of us. But generally, no, we're not putting patients to sleep. What most of us are doing is very, very minimal light sedation, if any at all. We do have occasionally patients who need general anesthesia, although I would suspect most of us are going to be talking with those specific patients that, hey, we need to do general anesthesia for you in those certain situations. The large majority of the patients, I would say 99 plus percent are going to be with just minimal light sedation and going home very soon after the surgery.
Sounds encouraging. Dr. Graham, could you say a bit about rosacea's effect on the eyes?
Sure. So rosacea is a skin condition that's quite common. It affects the oil glands primarily on the face and the eyelids. Rosacea patients get a rosy red hue to their skin across their cheeks. And in the eyelids, their oil glands can get clogged and scarred down. And this can contribute to dry eye. I'm the dry eye doctor of the day. So can contribute to dry eye because those oils need to get out onto the surface of the eye to stabilize the tear film, prevent it from evaporating, prevent it from just sort of breaking down and not making a nice sheet over the surface of the eye. So there are a lot of different ways to treat the oil glands to help with that problem.
Thank you. Dr. Kosick, after cataract surgery, a caller developed floaters interfering with reading. What could be done about it?
Sure, that's a great question. So first, a note about the floaters. These are likely within what's called the vitreous jelly of the eye, and they can happen with or without cataract surgery. So the jelly breaks down as we age, and bits can start to freely float around. It's often noted after cataract surgery, possibly because the vision is more clear. Just like you might notice a crack or a dent in your windshield the day after you have your car washed, once your cataract is out of the picture, you may notice other smaller visual problems like floaters. But it's also possible that the stress of surgery contributed to the breakdown of the jelly. And so this is generally a normal process, but it is worth talking to your doctor about and being seen because that jelly of the eye is sticky. And when it pulls away from the retina, there is a small chance it could pull or tear the retina. I would be more concerned if the caller noted flashing lights, because the mechanical stimulation of the jelly pulling on the retina will cause flashing lights even in the dark or with the lights off. It's worth following up with their doctor about, for sure.
Thank you. Dr. Graham, what is migraine of the eye?
Migraine of the eye, we often call it an ophthalmic migraine or an ocular migraine. It is a visual aura. We call it a scintillating scotoma because it has movement to it. Sometimes it's colorful, sometimes it's black and white and jagged, but it has motion, it has a progression. It tends to last about 20 minutes classically. Some people it really interferes with their vision, and some people it's minor. It can precede a migraine headache, so the ophthalmic migraine really doesn't have any pain associated with it, but some folks will have a headache afterward. If they're happening really frequently and interfering with your life, you can treat it with typical migraine medicines.
Thank you. Dr. Kosick, what is special about a new type of lens in cataract surgery that can be adjusted for its visual outcome afterward?
Sure. This is very new technology. It goes back to that discussion of premium lenses. And there is a new premium lens which we can adjust with a laser afterward. To my knowledge, I don't know of anyone in Duluth that has access to this. Oh, you do? All right.
Adjustable lens?
There we go.
Yeah,
yes.
we do the light adjustable lens.
That's great.
Yeah. A patient will go through a series of light treatments to adjust the power of the lens in the first few weeks after cataract surgery. It gives a more custom result, can treat astigmatism. So it's kind of a nice option for folks who can't have some of the other premium lenses, or folks who have a very sort of distorted cornea where it's hard to predict what lens implant power is proper. So
interesting technology.
it is,
Yes.
yeah.
Dr. Ahrens, a brief question we have time for. Any recommendations for the best vitamins or dietary conditions or considerations for eye health?
Generally, what I talk to patients when they ask this question is, if you're young, healthy, just a good healthy diet is the best thing you can do. Eat all your green leafy vegetables, things like that. If you're going to do a vitamin, just a regular multivitamin. If you smoke, quit. If you don't smoke, don't start. And that's just for general eye health.
Very good. Well, I want to thank our panelists, Dr. Charlie Ahrens, Dr. Matthew Kosick, and Dr. Lisa Graham, and our medical student volunteers, Barrett Bukowick, Kenny Knudsen, and Katie McLaughlin. This is our final program of the season. Our thanks to all the doctors, mental health specialists, and phone volunteers who've been with us throughout this season of Doctors on Call. We hope you have enjoyed the programs. Thank you for watching. Good night.